Thank you very much, Gail, and thank you everybody for being here. Professor Sierra already did an outstanding job setting the table for what we have done now with the treatment of these patients with FLT3 mutations. So, because of the known adverse prognosis of these patients with FLT3 mutations, and the fact that, as you just heard, these are kinases, there was a strong interest in developing FLT3 inhibitors for many years. And many of them have been developed, and some of them have already been approved and are available in the clinic. And they can grossly can be classified into two categories. What's called the type 1 inhibitors, which are inhibitors that work both in the active and the inactive conformation of the kinase, and then the type 2 inhibitors that only work in the inactive conformation of the kinase. So that includes sorafenib and quizartinib, whereas the type 1 include midostaurin, gilteritinib, and a few others. Now, here you see also the selectivity of these drugs, where in these kinome trees, every dot represents a kinase that's inhibited, and the size represents the potency against that kinase. The blue dot represents the FLT3 specifically. So you can see that there is a wide variability in terms of how selective they may be, with perhaps some of the older ones being a lot dirtier, like the startinib, whereas some of the newer ones are more selective, but there's still affect other kinases. Now, in practical terms, the distinction between the type 1 and the type 2 is that the type 1 inhibitors that, as I mentioned, work against both the active and the inactive conformation. They inhibit both the FLT3-ITD and the FLT3 kinase domain mutations, whereas the type 2 inhibitors, I remind you, sorafenib and quizartinib, only work against the ITD mutation. So that is an important thing to keep in mind. And we're going to be talking about what the clinical implications of these has been throughout the different studies. So we're going to talk first about the use as monotherapy, which is how these drugs were developed and how, at least for the moment, gilteritinib is approved. And as you can imagine, the initial development was in the salvage setting. And I'll start with quizartinib, which went through a very tricky road of identifying the optimal dose. So I'm skipping a few steps here, but eventually we went to this phase 2 study, which had two cohorts. The one that was older patients, age 60 or older, that were receiving their first salvage, and the other cohort that was adult patients, age 18 or older, who had already received one salvage therapy, so were receiving their second salvage. This study included both patients with FLT3-ITD and patients without FLT3-ITD. And it was clear that the patients with ITD had a very significant response rate with CRCs of around 50%, a little bit higher in the first salvage, a little bit lower in the second salvage, but very impressive responses. I'll just deviate a little bit to show you the response as single agent in the non-mutated FLT3 patients, which was a very respectable 30%, which set the ground of the study that Professor Sierra mentioned at the end, that has shown some activity in combination with chemotherapy. Because of the efficacy in that study, that led to the design of this study that was a randomized trial called the Quantum-R of patients that had received prior therapy. They should have received at least one cycle of an anthracycline-containing regimen, so essentially 3+7. And they all had FLT3-ITD. No TKD was allowed. They were randomized to receive quizartinib or the physician's choice of low-dose cytarabine, MEC, or FLAG-IDA. And then there was the option for continuation therapy after transplant or instead of transplant, depending on the eligibility of the patient for transplant. The primary endpoint was overall survival. And in the next slide, we can see that the primary endpoint, well, first let me show you the response rate. And as you can see, the response rate, the CRC, the composite complete remission that includes CR, CRP, and CRI, was significantly better for patients treated with quizartinib compared to the chemotherapy. If you throw in there also the PRs, the difference even expands a little bit more in favor of quizartinib. And then in the next slide, if we look at the survival of the patients, the primary endpoint, that was significantly better with quizartinib. You see there the median survival, 6.2 versus 4.7 months, again, highly statistically significant. And secondary endpoint, the event-free survival, was also significantly better for quizartinib among patients that were they're treated as per protocol. So this study was a positive study. However, the drug was not approved for therapy in the salvage setting. So quizartinib is not currently approved for that indication. Then we go to a gilteritinib. Gilteritinib, a type 1 inhibitor again, was investigated in a similar fashion. So here I'm showing you the results of the patients treated in the phase 1, phase 2 study. Again, this study also included FLT3 mutated patients, in this case, both ITD and TKD, and the wild type patients without mutations. The overall response rate, as you see, is similar. As I showed you with quizartinib, the overall response rate was 49, composite complete remission 37. In the wild type, it was much lower than we had seen with the quizartinib. This led then to the design of this study, which was called the Admiral, very similar to the Quantum R that I just described. Again, patients with a relapse or refractory AML with FLT3 mutation. In this study, it included both ITD and TKD, were randomized to receive gilteritinib versus the physician's choice of salvage therapy, MEC, FLAG-IDA, low-dose cytarabine, or azacitidine. And the primary endpoints, the co-primary endpoints were response and overall survival. And the next slide shows that the response rate, again, was better for gilteritinib, about twice as high when you include the CRs, the composite complete remissions, or when you include the overall response rate that includes also the partial remission. So both, this study also confirmed the superiority of a FLT3 inhibitor, in this case gilteritinib, versus salvage chemotherapy. But more important, looking at the overall survival in the next slide, you can see that the survival was also significantly better for gilteritinib, with a median of 9.3 compared to the median of 5.6 for the patients with the salvage chemotherapy. In this study, there was a trend in favor of gilteritinib for the event-free survival, although it did not reach a statistical significance. So this study, however, led to the approval of gilteritinib for this indication, and that is how gilteritinib is approved right now for refractory relapse FLT3 mutated AML. In the next slide, we can look at a summary of these two studies and look at their similarities and their differences. Both, as I mentioned, showed an improvement in the response rate. Both showed an improvement in the overall survival for the FLT3 inhibitor compared to the control. There were some differences in the design of the study. In the Quantum R, patients that were relapsed should have a short remission duration of less than 6 months, and they should have received an anthracycline-containing regimen. They were also, they could only have ITD, not TKD. The Admiral study included any prior therapy. It could have been a low-intensity chemotherapy, and also it didn't matter how long the remission duration was for the relapse patients. And as I mentioned, it included the ITD or the TKD. Those are important distinctions to understand. We don't know how they may have affected the results or not, but it is important to keep those differences in mind. because of the type of inhibitors that quizartinib or sorafenib are, as I mentioned, type 2, you can see here that the IC50 for the ITD, when it has in addition a tyrosine kinase domain mutation, either the DA35 mutations that we talked about earlier, or that F691L mutation, which is called the gatekeeper mutation, you see how much it affects the sensitivity to these drugs. So in the next slide, we did an analysis some time ago looking at for patients that had received either quizartinib or sorafenib. Remember, we were using sorafenib for this indication for some years before these other drugs were approved. We looked at how often they developed these kinase domain mutations as a mechanism of resistance on patients who lost their response. And we found that about 20%, 22% of patients had that as their mechanism of resistance. So that is definitely an important element. Now we know that resistance also can happen by evolution of clones with other mutations such as RAS and others. In contrast, gilteritinib has a very good activity. The IC50 against all these kinase domain mutations is very good, as you can see on this graphic here, although the F691L still has a much higher IC50 compared to just the ITD or the DA35 mutations. What's interesting is that with two different type 1 inhibitors, gilteritinib and one that's still investigational, crenolanib, you see the results of patients that have DA35. And as you can see, when DA35 is present alone, the response rate is low, 17% overall response rate with gilteritinib, 17% CR/CRi for crenolanib. When DA35 is present in the presence also of ITD, then the response rate is much better, 62% overall response rate with gilteritinib. So the context where you find the DA35 really matters for the response. Now we know that for targeted therapies, we don't look at them as single agent. We always want to look at combinations. So that was evidently the next step in the development of these drugs. And I'm going to talk about a few of the important studies. The first one is the RATIFY study. That was the first study that led to the approval of really on any targeted therapy in AML. It was a very difficult study to conduct that took a long time. But kudos to the team led by Dr. Stone that took it to the final results. These were patients that were adults, ages 18 to 59, that had ITD or TKD mutations and were randomized to receive standard chemotherapy, daunorubicin, and cytarabine 3+7 alone or in combination with midostaurin. There was consolidation, including midostaurin or placebo, and then maintenance or continuation therapy. Next slide shows that the overall survival really favored, as we know, the midostaurin arm. So that led to the approval of midostaurin. That is the approved indication for midostaurin. But when you look at the subsets of the ITDs, depending on whether they had low or high viral allele frequency, or the TKDs, you see that the TKDs tend to have a trend for a better overall survival and actually somewhat significant event-free survival. So the TKDs seem to do a little bit better in this context in this study. These are subset analyses, so you need to take that with some caution. And then the other study was very similar design. This is Quantum First. The main difference is that only FLT3-ITD is included here, but overall, same principle, 3+7 with quizartinib or with placebo, with consolidation and continuation therapy. And this study, again, showed a benefit in terms of the response rate for the quizartinib arm with a CRC of 71.6 compared to 64.9, although mostly based on CRIs, where the CR was very similar. But more importantly, on the next slide, the survival was significantly better for the quizartinib-treated patients, and that was why this drug was then approved also in the frontline setting in that same context, in combination with chemotherapy. Now, it is important to remember that the benefit may be related to MRD. So in the patients that are MRD negative after the induction or after the consolidation, there is a trend for benefit for quizartinib, but it is very modest. Whereas in the patients that are MRD positive, that's where you see a greater benefit in favor of the quizartinib. So the continuation of quizartinib over the consolidation and the continuation of single agent or maintenance seems to have a particular benefit. Again, this doesn't reach statistical significance, but there is that trend, particularly in the MRD positive. Professor Sierra talked about the co-mutations, so it was important to look at what happens on patients that have co-mutations. And what we see is that the benefit of quizartinib is still present when there is co-expression of NPM1, of DNMT3, or of both with FLT3-ITD. And so this is a summary of the studies, again, showing very similar results, but both improvement in the CRC more than the CR, and both showing an improvement in overall survival. Now, an interesting study was this one, looking at a different concept, doing lower intensity chemotherapy, in this case with gilteritinib, for newly diagnosed patients with FLT3 mutations. There were 3 arms, although one was dropped at the end. And so this essentially looked at azacitidine alone versus azacitidine plus gilteritinib. And in the next slide, you can see that, unfortunately, on this study, the overall survival was identical for the 2 arms. So it was a surprise. Many of us were expecting that this was going to be also a positive study, but it did not show a survival benefit. Now, when we look at this study, one thing that looks interesting is that when you look at this highlighted area among the TKD patients, now granted these are small cohorts, so always keep that in mind, but that subset of patients seem to be doing better with azacitidine alone compared to the other patients that had the ITD, which at least were equivalent. And if we look at this study with crenolanib, another FLT3-ITD mutation, this is a single-arm study combined with chemotherapy, and you see the overall results that look positive. But in the next slide, when you look at the subset analysis based on the type of mutation, you see that again, in the context of TKD, the response rate seems to be lower than in the patients with ITD. So it is very interesting that although these type 1 inhibitors seem to work when this TKD is by itself, whether you use the drugs alone or in combination with chemotherapy, they don't seem to show that particular benefit. So just to conclude, I'll just remind you that on the next slide that the targeting just the kinase is not enough. We need to look at other parts that affect the development of leukemia. Targeting the microenvironment, possibly immune therapies, is important. And that takes me to the conclusion, just to highlight that we do have very good inhibitors. There are different properties for type 1 and type 2 inhibitors, but the kinase domain mutations, although in vitro they look very good, they're still somewhat of a challenge. They don't have such a worse prognosis as Professor Sierra mentioned, but the response to the kinase inhibitors seems to be still something that we need to work on. So I'll stop here. Thank you for my attention.